Welcome to this webinar, Let's Code Together. My name's Jane Knight and I'm a clinical associate with the MSSO. I'm also a MEDRA instructor and I'm joined today by my colleague, Dr. Carol-Ann Wilson.
Welcome also from my side.
So we're pleased to have you with us. There's about just over 50 of you so far at the moment online. And we'd like this session to be as interactive as possible. So as I've explained, I think most of you've heard me say, we're going to be using the questions panel on the right-hand side. And we'll also be going to doing some interactive activities. And the details of that will be coming up on a slide. They're also in the chat section as well. The details are there. So let's get started. MEDRA first slide explains that MEDRA came about as an ICH initiative. The MSSO was put in place at the time to maintain and distribute MEDRA, and the activities of the MSSO are overseen by a management committee which has representatives from across ICH, both the industry and the regulatory authorities. The next slide is a copyright notice that explains that MEDRA is owned by ICH, as is the material that we're going to present today. So if you choose to use any of the things that we show you, if you do choose to use anything, please do acknowledge MEDRA, ICH as owners of MEDRA. Now I'm seeing notices that people have got sound problems.
Yes. I've already answered.
Thank you. Want to make
participants will restart the session.
Everyone else can hear, hopefully. So that's the disclaimer. The next slide explains a bit more about the audience participation. I've explained about questions. The other point, just when we do say that, we are very keen to hear your comments and your questions. We want it to be in a workshop format. Sometimes it may be that the examples we use are not as black and white as we'd like them to be. And it may be that we don't all agree on the term that's the most appropriate one today, depending on how clear the terms are. And we will have the debate, we'll have discussion, and it may be that in the interests of time, we have to agree to disagree. So we just ask that we all respect that in the interest of each other's time. Also, I should make it clear, we can't take requests to code specific verbatims via the questions. If you have examples that you'd like us to consider for future sessions, there is an option with an online survey at the end here, as well as a follow-up survey. So please feel free to give us your proposals, but these must be of general interest to the wider audience, not something that just affects your company. So this is how we're going to be doing the participation. It's with an application called Poll Everywhere. You can access it through your mobile phone or through a computer browser. So you need to open an internet browser on your computer or your cell phone, so something like Safari or Chrome or something like that. And you type into the top pollev.com, pollev.com. You then, when it asks for a username, you need to enter my name, Jane Knight 855. This is the username, and this will allow you to link to the presentation. It's completely anonymous. You don't need to put your own name in at all. So just to, hopefully some of you've done that. If you didn't catch the details, it's in the chat, Jane Knight 855. And see where everyone is. Now I can see we've got someone in India, someone in the middle of the sea. Someone is that Turkey? Across Europe, the UK like me, France. Oh, widely, across the whole of Europe there mostly. A couple of people in India. Good. So I see some more people are joining us. Welcome if you're just joining us now. So welcome wherever you are in the world. Now, the other way we're going to make this interactive is by using a browser. Now, I shall do demonstrations. Carol-Ann and I will do demonstrations during the session, but you also may like to play along with us, as it were, to code along with us using a browser. This is the web-based browser. If you don't have access to a browser, here's a demo that we've set up temporarily for the session today. If you have your own credentials, you're welcome to use those, but this is just for anyone who doesn't have access to a browser. You can go to the medra.org website, go to the WBB shortcut at the top right-hand side, and enter their training and then the password you see on the screen. So you might want to take a snapshot of this screen if you do want to use that, because we'll be moving on. Okay, just leave that for everyone. Anyone who wants to use the browser can do so. So what we were saying, sometimes verbatim terms in real life don't always have an exact match in Medra, and this is a challenge. Sometimes you find there may be more than one possible approach, and even the points to consider document gives us options in places where there may be more than one approach. Sometimes it may be that we read a term differently, and Carol Ann and I notice this when we prepare sometimes. We understand a term differently. So what we do when we code, we look for the closest matching LLT. And if there isn't an identical match, we use medical judgment, or we have to make what we call a best approximation. But overall, the key thing throughout the session today is that we always code as reported and we don't make any assumptions. So bear that in mind as we go through the examples. And we always have one of these little pictures, don't we, to show sometimes coding is like this. It's not black and white. What do you see? Do you see a bird? Generally, most people see a bird, but if you tip your head to the side, is it a bird or is it a black cat sitting on what looks like kitchen tiles with their head tilted to the side? Do you see it? And sometimes I find verbatim terms are just like this. What is it? So medical judgment, it all comes down to a balance between applying the coding rules from the points to consider and maybe your internal conventions. That gives us consistency. But sometimes you need to apply medical judgment, and this is all to manage risks to patients. So it's a term-by-term judgment in some cases, but never conflicting with the points to consider rule coding guidelines. Medical references are helpful, and you'll see that with the examples we've chosen today. And sometimes it may be necessary to request a new term to be added to Medra to represent the reported concept if you can't find something in Medra. So let's get going. I see we're 8 minutes in, so let's code together. I'll start with the first example. A large obstructive adenoid. This is what's been reported. Now, what's happening here? Is this term clear enough? Do we know what's being reported? And can we find a suitable LLT? Well, what's it telling us? The adenoid is large and it's making some kind of obstruction. So if we look at where the adenoids are, they're here at the back of the nose, the nasal passage. This shows you the tonsils and the adenoids, often talked about together really, similar tissue, adenoids and tonsils. So there are the adenoids at the back of the nose. So what you think of with the obstruction, it's probably some kind of nasal obstruction caused by large adenoids. So what would you code that one to? And we did send out the terms ahead of time this time. So some of you may have already had time to consider these and have a browse in your browser already. What would you code this one to? Adenoidal hypertrophy. There's a loud and clear. Adenoidal hypertrophy, adenoidal disorder. Adenoidal hypertrophy. So we're getting a split here between the two. Some of you have done your homework, it seems, by looking. You're quick there. So let's see. Now, what if I were to ask you another question? When you look at that term, what guidelines from the Medra term selection points to consider can you think of that will help us? So adenoidal hypertrophy, lots of you are suggesting that one. What comes to mind? Now, when I see that term, I always think, when I see any verbatim, what is there in the points to consider that can help us? No, I think we're still coming up with we're a step on, aren't we? Well, let me show you what I was thinking. Is it nasal obstruction? Well, if we view it as a diagnosis with signs and symptoms, so the adenoids are enlarged, That's our diagnosis. And the nasal obstruction or the obstruction is a symptom, isn't it? It's a symptom, or it's related to the underlying cause being the enlarged adenoids. And the points to consider document tells us that if we have a diagnosis and assign a symptom, it's sufficient to code the diagnosis. So that's what I would apply here. Also, this is an interesting one that I often bear in mind when I'm coding. If you can't find the exact term that you want at that particular body site, it's better to code the condition with the closest site you can, or as a general condition, rather than a disorder at that site. However, the points to consider document also goes on to say, again, you need to use medical judgment, because what you don't want is to choose something which is so unspecific, it doesn't have a body site, that you actually need to use the site. So it's a balance. Generally, we're interested in the condition more than the site, but you need to use medical judgment for that. So let's have a look in Medra and see what we've got. I'll go to the web-based browser here. So I'll go to the website, click on the web-based browser link, as I've suggested you do. I've got my login credentials already stored, and here we are. So let's have a look at large adenoid, because that's the wording that we've been given. Nothing. So enlargement, enlarged, there's nothing. So there's our nasal obstruction probably. Let's have a look at that one. That's the other thing, but I'm more leaning towards the diagnosis if I can. So we've got a nasal obstruction. That would be PT, and that's in upper respiratory. But I would rather capture the condition. So what's another name for enlargement? I suppose you could say it's swollen, or it's... Let's have a look. I'll tell you what I'm going to do. I'll have a look and see if there's enlarged at any other body site in Medra and see how those terms are grouped. Oh, I've got a lot of enlarged terms here. I've got abdomen enlarged, aortic. Can you think of anything that might be useful? I would look down, and so I don't have tumor enlarged, thyroid enlarged. That's a goiter. Thyroid. What else have I got? What about the tonsils? Have I got anything tonsils? No. Enlarged. There, enlarged tonsils. What about that one? Now that one's an LLT. That has a PT of tonsillar hypertrophy. So it's treating the enlargement as a synonym of hypertrophy in relation to tonsils. And I can go across to the browser, which is always good practice to do. You can see it here and have a look. So tonsillar hypertrophy is a PT, and we've got enlarged tonsils there. So based on that, I wonder if we would have adenoidal hypertrophy, and that's what some of you, I think, had already done. And we'll see what we get here. Adenoidal hypertrophy is the LLT, and that's what you gave me beforehand. So pharyngeal disorders, and that's what's causing the obstruction. So I'm quite happy to go to choose that one as the cause, and I don't feel there's a need to capture the nasal obstruction separately. So that's how I would deal with this one. I would understand the body site that has been reported, and then I would use medical judgment to capture the condition, avoiding a less specific disorder term. So I would prefer not to choose adenoidal disorder because it tells us so little. I would use Medra term placement, as you saw me do with the tonsils, and I would follow the guidance that I gave you from the points to consider document. Have a look at the next one. Do we have any questions? Let me just have a quick look there to see if anyone's commented. I think most of you were with us on that one. I saw no one else, just the sound issues by the looks of it. Could you repeat the password? That's all. Everything else is good. So let's have a look at this next one. IPA or EPA, creatine phosphokinesemia. That's a mouthful. What's being reported here? Well, it looks like it's either come from another language that's not English, or it's a misspelling. I would read that as probably hypercreatine phosphokinasemia. Well, that sounds like a substance. They've made it into a condition. When the spelling is modified, is there a matching LLT? What does this mean? What's the closest matching LLT? Hypercreatine phosphokinasemia. So what will we do with this one? How would you handle it? Would you look to code it? Would some of you query it based on the misspelling or non-English reporting? You would seek clarification. Creatine phosphokinase abnormal. Increased CPK. Look up creatine phosphokinase, thank you. Query for clarification. Well, we're split, aren't we? Again, it's this, some of you might like to query. It's fine if you want to query terms, but sometimes you think, well, we don't want to annoy investigators by asking something unnecessary if it's obvious, or sometimes you just don't gain very much. So let's have a look at what our next slide says. Points to consider. The investigations system organ class includes test names and it includes the names, the high, the low, as we know. And these are there for coding test results reports. The example in the table says, if something is reported as a test name or test result, you should always code it into the investigation SOC. And that's what we see with decreased glucose. If something's reported as a condition, so hypoglycemia, we would code that into the body site or here metabolism for hypoglycemia. So this is the difference. This is quite a strong guideline in terms of coding. You'll also see examples in the companion document for coding. So let's have a look. Ideally, I'm looking for a lab result, a condition, because it's got emia on the end, creatine phosphokinasemia. So let's have a look. Creatine phospho. I don't need to type the whole thing in. For quickness, I'll do it as I would if I was coding every day. Let's have a look. Blood creatinine phosphokinase. There's creatine phosphokinase. There's the test name. There are the abnormal, increased, decreased. Well, emia suggests that it's increased to me. That means it's like hypoglycemia in the blood, hyperglycemia, high in the blood. So we've told ours as hyper or hyper, so we know it's high, but really I would have liked a disorder term, something that isn't in the lab results. And when I look down, these are all lab results. There's nothing there that falls into the body site. So what do? Do I lose the specificity of what's actually been measured in order to get a condition, or do I go for one of these terms with an increased creatine phosphokinase increased? This one, blood creatine phosphokinase increased, or phosphokinase increased here without adding the blood. Creatine phosphokinase increased. If we look at this one, this will be in the investigation SOC, as we'd expect. It's not ideal, but there isn't a condition that captures what we've had reported. And this is where you do need to use your medical judgment. So I agree with you, those of you who did put at the beginning, I would code it, I wouldn't query it. I would take it as being hyper, and I would code it to the lab result of creatine phosphokinase increased, but just bearing in mind that I'm doing that because I don't have a condition. Here's another example. Newly detected increase of urinary orotic acid. So here it's been reported as a lab result. It's the opposite of what we had before in our example. We had a condition reported, which it seemed like the investigator had made it up from the lab result itself. Here, we're not able to capture a lab result in MEDRA. We're forced to code it to the disorder because it's the only way to capture the concept, the medical concept. There is no other way. Ideally, I would code it to a test result, but there isn't one. Perhaps I might request that that is added to a future version of MEDRA. Potentially, I might send in a change request, But in the meantime, this is the closest LLT. So although it seems like it goes against the points to consider guidance, it's because there is no other option. Is that clear with everyone? Do you have anything to add there, Carol-Ann?
Nothing to add.
No. So this one I referred to the points to consider. Use medical references to make sure you understand, especially if you're having to look for synonyms. Train your coders to apply the points to consider, but also use medical judgment with a documented rationale. Select the LLT from the investigations where possible, and if this is not available, then you can look for a corresponding event term, but only when there's nothing available. So,
Jane, we have a question.
Yeah.
We have a question for the first example.
Oh, yes.
We are told that the obstruction is a complication of the adenoidal hypertrophy or enlargement, so it should be captured separately.
Yes, well,
it's not to be considered a symptom.
And that, again, that's the judgment. If that's the way you feel more comfortable doing it, that's fine. Yes, is the obstruction a complication? Is it something that happens when the adenoids are enlarged? Also, the way that it was described, it was obstructive. It was describing the enlargement. That's what tipped me over into the way it was worded, a large obstructive adenoid. It wasn't saying nasal obstruction due to enlarged adenoids. The subtlety of the wording made me go for that one. But it wouldn't be very strongly wrong if you did choose to regard it as a complication. But I personally don't feel that there is a need for that. What do you think, Carol-Ann?
Yes, I agree. I would consider this as a symptom, a more severe symptom, yes, but it's a symptom.
But if you choose to split code, then that's fine.
Yeah, it's always difficult if you have symptoms that indicate a much more severe condition. If you consider this as a symptom and subsume it under the diagnosis, or if you would rather separate it and split the term and code it separately. There's another question. Just one moment before
That's
I
fine.
start.
I'm hand over the presenter rights to you now, Carol-Ann. While
so
we have
there's a question. Would this be something, for the second example, would this be something that needs to be included in the company conventions, coding convention?
You could do, yes. You could have that says when you can't find a term in the investigation SOC, supposedly, or you can't find the corresponding body condition, it's better to capture the detail of what's actually happened to the patient, because ultimately we're interested in patient safety. So you could have that in your internal conventions. I used to code. I still do code as well to some extent, but only in my coding career, only a couple of times have I ever come across this, a handful of times. It isn't something that happens very commonly. It wasn't something that happened to me very commonly.
I agree. So when I was working in pharmaceutical industry, we had it in our company coding conventions.
You did.
So that coders knew what to do in such instances. So related to the symptom, the obstruction for the adenoidal hypertrophy, you did mention that it goes against, we should not go against PTC, and now we have the rule. You said that the obstruction should not be coded separately. So I think this means that, of course, we should not contradict PTC guidance, but the PTC guidance clearly indicates that if we have a diagnosis with signs and symptoms, we are allowed to only code the diagnosis. In this instance, the diagnosis was the adenoidal hypertrophy, the enlargement.
But as I said, if you feel, when you apply your medical judgments, if you feel that should be split, it's fine. It's fine to split and capture the nasal obstruction if that's what you feel is the way to go. That's fine to do. I personally would go with the adenoidal hypertrophy, because when the adenoids are enlarged, what you would expect is that there would be some degree of growing obstruction. So that's why I would do that. That is the clinical picture that you would expect with enlarged adenoids.
Okay.
Yeah, I think that's fair. That we're not saying you're wrong. I wouldn't do that.
Okay, then I will continue.
Thank you.
With my examples here. And we are now starting with the examples that relate to COVID-19. So a topic that is very acute currently, and you may struggle with some of the terms that are available in MEDRA. So in the first example, we are told that we have that there is a positive swab test result for COVID-19 in a patient that is asymptomatic. So is this term clear enough to code, or do we need additional information in order to do so? Can we derive the type of test that was used from what has been reported? And is this a test result actually that was reported, or is it a confirmed or suspected COVID-19 infection? Is it a provisional diagnosis? So how to handle this? Oops, I cannot move it further. Here we are. So use your browser again to find the most appropriate LLT. SARS-CoV-2 test positive, COVID-19 virus test positive, provisional diagnosis. What else do we have? So most of you are voting for the test results, but some of you also would vote for asymptomatic COVID-19. Plus the lab test. Okay, so let's see. So we have these additional terms in MEDRA, that is the LLT and PT asymptomatic COVID-19 and the LLT PT suspected COVID-19, in addition to the lab test results. And now how to differentiate these two PTs? How to differentiate them? How can they be distinguished? We are now looking at MSSO response for a change request for a new LLT COVID-19-like symptoms. And this change request was rejected. It was not approved because it is too vague for inclusion in MEDRA. Instead, an alternative is proposed here. So if you have COVID-19-like symptoms, then you can use the LLT and PT suspected COVID-19, because this is like a provisional diagnosis. Of course, if you have specific COVID symptoms reported, you would always have to code this, extract and code them separately. But if you just have a vaguely reported COVID-19-like symptom or symptoms, then you can use this LLT, suspected COVID-19. Now, what about the LLT and PT asymptomatic COVID-19? A diagnosis of asymptomatic COVID-19, of course, can only be made based on lab results. But what we have here is one positive swab test result. And is this sufficient to really confirm a diagnosis? In my view, it's definitely not sufficient. We don't know whether a reliable PCR test or a less reliable antigen test was used, or whether the test result was false positive, maybe, or the specimen collection may not have been appropriate. So it would need more information to code the diagnosis asymptomatic COVID-19, because this would be a diagnosis. So what should we finally do with this verbatim? What would you do? Is there a MEDRA term? Is there any guidance in the MEDRA term selection points to consider document that would help us to resolve this issue? Where would you refer to? Jane, just a hint, Jane already provided a similar coding scenario with a second example before that related to the distinction between diagnosis and lab values. Yes, it's the part, it's again the part, section 3.14, where we are clearly advised that we must distinguish between diagnosis and related lab results. So our verbatim does not provide a diagnosis, but just one lab test result for an asymptomatic patient, and therefore we should look for a suitable term in SOC investigations. Thank you for joining. Yes, investigation SOC would be the appropriate SOC to look into. So which LLT would you then select in SOC investigations? Would you select COVID-19 antigen test positive, COVID-19 virus test positive, the molecular test positive, or PCR test positive? So you really did your homework. Mm-hmm. Some of you vote for PCR tests. There were also one that voted for antigen tests. So we see that we have very specific LLTs that are available in MedRA. So let me switch to my browser now, hoping that it's still there. Session time's out. Let me log in again. Here we are. And let's do a top-down search in SOC investigations. So we would look into SOC investigation. We would find HLGT microbiology and serology investigation. And here, of course, we would select HLT virus identification and serology. Now, if we scroll down, we will find the coronavirus test, PTs. Just a test term, then the test terms with results, negative, positive. So don't stop there, but look for even more specific terms. So you have to scroll down, scroll down. We have all these infection terms. And here we are. We have SARS-CoV-1 test terms, and we have all the SARS-CoV-2 test terms. So what we have to look for is our test results here. Let me show you, switch back to, so what we could also do is, of course, what I would like to show you is to not do a top-down search, but also a bottom-up search. We could just restrict our search to SOC investigations and enter COVID-19 or SARS-CoV-2 and search.
I think that's the safe way to do it, Carol-Ann, because
yeah, that's the easiest way to do it.
I could have easily seen myself falling into the trap of stopping when I got to coronavirus, seeing it wasn't there, and not scrolling down to SARS.
Yeah, this is what happens if you don't look for more suitable neighbor terms.
You don't think about SARS. Yeah. So I think that's a better approach.
Yep. So this is what I wanted to show you here.
And we've got a couple of comments that someone's saying that when we did the multiple choice, they would regard most of those options as assumptions. They wouldn't feel comfortable then making an assumption about the type of test. So you're going to explain to us now, aren't you?
Yeah, I'm explaining it now. So I just wanted to show you where to find it. Here you see the screenshot of the first ones that we saw, the more vague terms of coronavirus tests. And here you see the more specific ones that are available in MedRA that relate to SARS-CoV-2. And here we have our LLTs. So let's look into these. We have some very specific terms that relate to molecular tests, so PCR tests, where the genetic material of the virus is detected by multiplying virus genetic material, the RNA. So we were not told that this was a molecular test or PCR test. Then we have the antigen tests. The antigen tests do not, they detect proteins of the capsid, of the shell of the virus. They are less sensitive, and so the PCR test is the gold standard. These are less sensitive, and we have another term that also relates to an antigen test, that is the rapid POC test positive, point of care test positive. So these are the bedside tests that you can use to have a quick impression whether a patient may have the COVID-19 infection. So we cannot derive any of these informations from what has been reported in our instance. So the best term here to select would be COVID-19 virus test positive. And most of you have voted for this one.
Don't make any assumption. Another comment comes in that when you were first looking at the term, you seemed to be suggesting that the test result was unreliable, was inherently unreliable, but our attendees suggest that we're not in a position to judge whether the reported result is unreliable or not.
No. This was just a positive test result.
Yeah.
And there is no doubt. There was no doubt that was expressed related the validity of the test result.
No, we wouldn't capture any unreliability in coding, because what we're told is that the test result is there, and we would code it as that.
It would be an assumption. Yeah, it would be. But we have another example that relates to this issue. We will come to this with another example that we will discuss today. So this is now what we can take from this example. And I would really like to emphasize that we always have to clearly distinguish between test results and diagnosis, and adhere to the relevant guidance in the meta-term selection points to consider document, as Jane already mentioned. When knowing in which direction to go, when knowing in our instance that we have to search in investigations, you should always search for all possible LLTs and PTs, doing top-down and bottom-up searches, and by looking at neighbors of somehow suitable terms, to not overlook a better term, a more specific term for your reported condition or event. And when coding, we should not make any assumptions. So like in this example, we should not derive a diagnosis from a reported lab result. So, any further questions?
Yes, there's another question. So our group are telling us that SARS-CoV-2 does mean COVID, which, yes, and then so why not choose SARS-CoV-2 test positive? Why did you go for COVID-19?
Yeah, because SARS-CoV-2 was not mentioned in the verbatim.
Yeah.
Of course, the SARS-CoV-2 test positive would also be correct, but usually we try to stick to the wording in the verbatim as much as possible. And, you know, these are really to be considered synonyms. And then I would just code to COVID-19 virus test positive in this instance.
We're matching the wording. There's someone else who's saying, when you think of COVID, it's got the D means disease. So why are we using that as a test? Well, I think that's because with the current situation and the way people are using wording, aren't they? They're using COVID-19 as it is quite colloquial, if you like, but that's the way the reports are coming in. So to help auto-encoding, that's why we would match the wording. Long term, the terms may move, but it's just the way the situation is.
Yeah, so. This is just based on reporting practices. Yeah, this is how it is reported in many instances.
And another comment is saying, would coronavirus test positive be correct? Well, it wouldn't be wrong, but it
wouldn't be wrong, but it would be too unspecific. It would be too vague, because it could be any coronavirus. There are many coronaviruses. As you can see here, we also have the COV-1 COVID coronavirus, and there are other coronaviruses as well.
And then one of our others are asking, one of our other attendees is saying, shouldn't we also code the asymptomatic COVID-19? I think you covered that one, Caroline, as well.
I covered it, yes, with the two examples about the asymptomatic COVID-19 and the suspected COVID-19 infection. So this would be an assumption. We are only having one test result, so we cannot derive any diagnosis from it. No. Of course, an asymptomatic COVID-19 infection can only be detected via lab results, but I doubt that one lab result would just one lab result would suffice to derive this diagnosis. You would need additional information in order to do so. Yeah. Either repeated tests or more like risk factors, contacts, whatsoever.
Thank you. So let's go to our next one. Shall we? Do you have?
Yeah. So the next one is an unreliable negative COVID-19 test result due to a poor technique in self-testing process. So this was reported. So we are still with the lab test here. So here, how can we best capture this? Do we need to split or assign more than one LLT, or just leave it with one LLT? And does this represent a medication error, or maybe a device use issue, or may this relate to patient non-compliance? So what LLTs would you select? Would you split or only assign one LLT? Yes, you would split. Of course, there are two incidents reported here. Product usage, COVID-19 virus test false negative. So that there's a split of opinions here. Split in different LLTs. Yes, there seems to be consensus here. False negative, wrong technique, false negative, false negative. So this seems to be so we have a split of opinions here. Let's browse and see what we can find again. Let me switch back to my browser. Go back to my COVID-19 related terms. So here we are. I click on one of these, go to browser again, and here we are with our SARS-CoV-2 terms, and see what we have. So we have the SARS-CoV-2 antibody test. So we don't know whether this was an antibody test. It was not. It was a virus test. Test false negative. This would be, so antibody test is not appropriate because we are not told it was an antibody test. It was a test to identify the virus. So here SARS-CoV-2 test false negative. Would this be appropriate? Could this be taken? So many of you have chosen this one. We are told it was an unreliable test result, but it could really prove correct on further testing. So we cannot assume that this was false.
No, I wouldn't assume that was false. Yeah. It could be. It's just unreliable. It's come up. Yeah. It's come out like that, but we'd have to retest.
Yeah. So can we assume that it was a SARS-CoV-2 test that was negative? Again, a negative test result is reported. This test result was reported as unreliable, so we cannot assume that it is correct and choose this LLT. Now let's check whether we have maybe unreliable test results.
Well, that would be, I prefer that if you had something that was unreliable or
So we have, I have still
nothing.
Still limited my search in SOC investigations, but
unavailable. Unavailable.
Yeah, look for synonyms and check for unavailable. You know that there's terms like unavailable reaction or so. Maybe there's also something for lab results. Oh, and we see in SOC investigations there are two PTs, unavailable investigations and unavailable specimen. So we are told that the lab test result is unreliable. So it's not the specimen actually, it's an unavailable investigation. Again, go to the browser and check what we have. Didn't work. Here we are, unavailable investigation. So there is no more specific LLT under this PT that we could choose. So this is quite vague, and we are not really satisfied with this one. What you can do now is to check in the supplemental view of the browser whether a more suitable term may become available with the next Medra version release. And I will again enter unreliable, no results, and then unavailable.
Unavailable.
And again, limit my search to SOC investigations. And here we are. We have a green dotted line around it. So this is a supplemental term that will only become available with the next Medra version release. And it's unavailable test result. So this is exactly what we need. And when we click on it and look into the hierarchy, then we see that this new LLT will reside under PT unavailable investigation. So we can take this LLT unavailable investigation as an interim solution for our verbatim, because
would you code the COVID negative as well, Carol-Ann? Would you choose that in addition to the COVID-19 negative?
I wouldn't.
You would just choose this one, would you?
I would just choose this one, yes. Because we don't know whether it was false negative or whether it was negative. So we don't have information that would allow us to take this assumption here.
Yeah, I see. Yeah, I just wonder, I wonder if I might think about capturing it and that as an additional term, possibly, but yeah.
Yeah, but as I said, it could be false negative.
Unreliable, isn't it? Unreliable, so unavailable. It's probably the best way.
Okay, let's switch back to our presentation. Here, just a reminder that you should always look into the supplemental view of the browser. It will also save you time that would be needed to submit a related change request. Now we have found a suitable LLT now for the unreliable test result, but we still have to find an appropriate LLT for the second part of our verbatim, the poor technique in self-testing process, meaning the poor technique when either collecting the specimen with a swab or when a poor technique when handling this specimen with a test kit. And if you're not sure how to code such terms, then I can only highly recommend to refer to the so-called points to consider companion document, because this companion document really provides even more detailed instructions, more examples for the area of unauthorized product use and product use issues, device use issues, and also product quality terms. So if you are not aware of this document, please check. You find it under supplemental documentation on the Medra website and check it, because it's really very useful. And here is what you find in this document that is relevant for our example. So what we are looking at, of course, is a device, because it's a COVID test kit for self-testing. So we are looking at a device. And the guidance here says that what our example is not that we have an issue with the device itself, like a malfunction of the device, but what is reported here is that the way the device is used by the person, this way is not appropriate. So, and we have the document provides us with two options here. First of all, to use the LLT and PT device use error, so a very vague term that could relate to many other use errors, or to a more specific term that would be wrong technique in the device usage. And the examples that are provided for these technique issues is, for example, the incorrect needle gauge used or wrong injection technique. Now, what LLT would you select for the reported poor technique in self-testing process now, based on this guidance? Would you select device use issue? Would you select device use error, wrong technique in device usage process, improper use of device, device difficult to use, or investigation on compliance? So yes, most of you have on the correct path here. So device use issue, device use error, and improper use of device are much more vague terms. They could relate to many different errors in the usage process of the device. What is reported here is specifically a wrong technique. So we have a specific LLT for it, wrong technique in device usage process, and this would be the appropriate term. Device difficult to use rather relates to a device quality issue. It's difficult to use. In investigation non-compliance resides in social circumstances, and this rather describes the behavior of a patient who, for example, repeatedly misses appointments with the attending doctor for medical investigations, like, for example, blood withdrawals. So the correct term here would be wrong technique in device usage process. So what can we learn from this example? First of all, we should capture all relevant reported information when coding. And in order to do so, here we needed to split encode to two separate LLTs for this verbatim. When not finding a suitable term, check the supplemental view of the browser to see whether a new, better term will become available with the next version release. So it will save you time you would need for submitting a corresponding change request. And like always, you should browse thoroughly when confronted with unusual or more complex coding scenarios to make sure that you get a full picture of all potentially relevant suitable terms. And you should look for guidance in the PTC documents, not only in the meta term selection points to consider, but also in the companion document for more detailed guidance. And with that, I give it back to Jane now.
Thank you, Caroline. Just as we do the switch over, we have got a couple of questions. So yeah. The group is saying that, are you comfortable that a test is a device? And there was a suggestion of wrong technique in product usage because of a test is not automatically a device.
Yeah, but these it's a self-testing test. So these self-testing tests are like test kits that are provided, where you get a swab in order to take to collect the specimen, and then you have to process the specimen with certain parts of this test kit. So it's really a device because it does not only, it's not just a lab test result from a lab where blood is analyzed, but it's really like a little test kit that is used for this self-testing process. That's why I think
the word technique makes me think that there's something. It's not going to be a blood, because it's self-testing, so it's some sort of kit. And if that was your product, if you were dealing with the devices, you would know what it was, depending on your situation. Yeah. But I would feel comfortable to go with device as well. But there is the product if somebody is uncomfortable.
These are these rapid test kits that are available for point of care testing, bedside testing, or self-testing as well.
Oh, I've gone to, where have I gone now? Which one should I be on? We're on, am I right? The swab. Right, so can you see, this one? Got the second COVID-19. Shall we move on to the next one?
Yes.
This person got the second COVID-19 vaccination too late. Can you see it?
No, I cannot see it yet.
Okay, just bear with me while I get control back on the browse on the screen then. There we are. Can you see that?
Yes.
Got second COVID vaccination too late due to an interruption of supply because of high demand. So what's happened here? We've got two things happened here, haven't we? We need to capture all elements. Is it a medication error, a product use issue, or a product quality issue? And that's what we're bearing in mind here. We've got the issue that the patient got their vaccination too late, and the cause, the root cause, which is important, is the interruption of supply because of high demand. So what multiple terms will we select here? What would you do? I know some of you have done preparation. Product supply issue, inappropriate schedule of product administration and product supply issue, drug shortage due to pandemic. I'm seeing somebody, they're including the pandemic there, product supply issue, product availability issue. So let's see what we've got. Inappropriate schedule of vaccine administered, product supply, product availability. So let's have a look and see what we would do here. So I'll go back to my browser. So I've got the late receiving of the injection as well, the one I'm going to do first. So I'm going to look under the medication errors for that, the injury, poisoning, procedural complications, medication errors. I'm going to do a top down, and I'm going to look at an administration error. So the patient got their vaccine, but they got it late. So I would look down, product administration errors and issues. And there's a term immediately I see there, which is an incomplete course of vaccination. Well, it's not that, because they did have their course. They did have the complete course, but it was the wrong schedule. And some of you mentioned the word schedule there. So let's look at the LLTs under inappropriate schedule of product administration. And there we have inappropriate product schedule of product administration, or even better, inappropriate schedule of vaccine administered. There are some other more specific terms based on being drugs and the dosing schedule, but for ours, I feel comfortable that that would be inappropriate schedule of vaccine administered. And now we want to look for our next one, which is the supply issue. There's an interruption in the supply. So let's start with the word supply and see what we find. Drug supply chain interruption due to pandemic, or product supply chain interruption due to pandemic. So this, as an LLT, we would, because it's a vaccine, I prefer the word product. We've got product supply issue due to pandemic. That is better. Let me just have a look in the supplemental again. So I changed the format of the browser, the version of the browser. It's logged me out. I didn't mean to do that. Let me change it to supplemental just to check that there's no other supply terms being added. With the current pandemic, we're adding terms as they are needed. No, there's nothing come up there. So I would stick with that one. Product supply chain interruption due to pandemic is where I would go with that one. Let's go back to our. So we would capture all that's been reported. I would separate the event from the circumstances here and be clear on the cause of the event and the intention. That's what we always say when we have medication errors and issues. Be clear, is it an error or is it an issue? And as you saw me do, I would do top down, but I think most of you who responded had already done this search ahead of time. And I was looking in the companion document last night, and it was explaining that when you know that it's due to a quality issue, so here the quality issue was the supply, that's the reason why the vaccination was given late. So although it was out of the control of the of the healthcare professionals, it was due to a supply, but that's still a defect, this time in the supply. And when it is due to a product quality issue that you would select from the product issue SOC, then that's when you would then code it to a medication error. And that's what we did there. I didn't show you the SOC. I can go back and show you that this product supply interruption due to pandemic, it was very naughty of mine. I didn't show you the whole hierarchy. It's a product supply issue. It's in product supply, distribution and manufacturing, and that's in our SOC product issues. So that's where all our product defects are. Product supply chain interruption due to pandemic. And I can go back to the browser and have a look at that one there, just to make sure. Product delay due to pandemic, other ways of saying it really, import channel. You see the various LLTs that are available there on the left-hand side, but I'll stick with the one that I first saw, product supply chain interruption due to the pandemic. Now, we had to think that one through, didn't we, Carol-Ann? We had quite a discussion about that one.
Yes, because on page 22 of the companion document, we have some examples that clearly say, and these relate to dose omissions that are due to availability or drug supply issues or financial issues on the patient side, that they should not be coded to product use or drug use issues or use errors, but rather to be considered therapy interruptions. And therapy interruption the LLT resides in SOC surgical and medical procedures. Because remember the definition of medication errors. So it's all deviations, accidental deviations from the authorized product information when the drug is under control in the medication use process, under control by either healthcare professionals or patients and consumers. So the example that we have here is really not under control of the patients and consumers or the healthcare professionals. That's why I was in doubt whether we should select a term from the surgical and medical procedures SOC, but there is no suitable term there. The only term that is available is therapy interruption. And of course, the vaccination is not a therapy. So it's really not black and white here. You could select a suboptimal code in surgical and medical procedures, or you could select a term from the product use issues and medication errors grouping in MEDRA in SOC injury. But actually, it's not a use issue or use error on the HCP or patient or consumer side. It's really a supply issue. It's not under control of the patient. So either you code specifically the deviation, taking into account that it's actually not really a use issue or use error based on the definition of medication error, or you choose a suboptimal term in surgical and medical procedures. Mm-hmm. So this would rather require a change request, I guess.
So we've got some comments here. We've got some of the group questioning whether we can assume it's due to a pandemic. And my take on that one is that because it says it's a COVID-19 vaccination, and we know that we're currently in the context at present that there is a pandemic, that's why we're taking it as the interruption of supply because of high demand. We are in a pandemic at the moment when the case was being received. That's why we've made they're suggesting is it an assumption to code it to due to pandemic. So that's one thing. The reporter hasn't specifically said it's due to pandemic. But my feeling is it is due to pandemic because we're living in a pandemic. We know that at the moment, and they're talking about a COVID-19 vaccination at this time.
And it's a high demand, so it really fits.
High demand at the moment. And then someone is asking us about the supplemental terms and what you do because you have to get the cases in with regulatory requirements, we can't wait around for supplemental. And that's a good point. It's good to know where the supplemental terms are being placed. I use it as a guide because if I see, well, that's where the new LLT is going to be placed, then I know the region of MEDRA that I should be looking to choose the best possible term that's available at the moment. So that's how I use the look for the supplemental. It helps me as a guide.
Yeah, that's the first. And if you are working in a larger pharmaceutical company, you may use a synonym list as well for coding purposes. And then you could immediately insert this new supplemental term as a synonym, and these terms will then autocode in the future.
And then the question is the difference between supply and availability. Well, I was unclear of this until I read the companion document last night, really, in preparation. And I see availability as being more general. The drug is not available, but we don't know why it's not available. Whereas supply is more specific. It suggests that there has been a breakdown in the supply chain. And that's why, that's the way that I read it in the companion document. So that's how I read the difference between supply and availability. Supply I see as being a defect in the supply as part of the process of getting the drug, whereas availability could be a number of things. It's more general. That's how I see those. Here we've got the survey. So we have an online survey. Just so as you're aware, we do have 2 surveys because these sessions are quite new still. Carol-Anne and I are learning as we go, and we are responding to your feedback, which was why we sent the terms out ahead of time today, ahead of today's session. We are interested in your comments. So we've got this quick online survey now, and then you will get an email survey emailed to you. So it's fine if you want to complete one or other of the surveys. If you want to give us comments on both of them, that's wonderful. But I understand in case you think, oh, I've already done a survey, that's why. We've included this extra online survey in the polling app just because we're very keen on your feedback, and it gives you an opportunity to suggest some terms for us to use in future sessions. We are doing these sessions every month. We've had a lot of feedback saying that the session should be longer. That's something I think we will consider over time. But for now, we think an hour a month is a good opportunity for people to join and give your opinions. And it takes us a lot of work as well, thinking them through and preparing. So that's why at the moment we're sticking with the hour. Today we have the first session that we're doing in the Americas time zone this afternoon, in European time this afternoon. And we'll see what feedback we get from that as well. So we will be back next month. The number of spaces is limited. And this is why, because we couldn't cope if we had 500 people online for the session, we wouldn't be able to address your questions and comments. So I would urge you that if you do sign up for a future session and you can't come, please do let us know so that we can reassign your place to somebody else. Over time, I hope that we will quicken up maybe and cover more, but it depends on the topics we get and the questions and how much discussion they need.
Yeah, so let's continue with the 2 remaining COVID-19 examples next time, and with some other examples that relate to other coding scenarios. If
you want to come next time and you can't get on because it's full and you've missed it today, send us an email in response and we'll see if we can squeeze you in next time, because I'm aware that you've done your preparation for the session and we haven't covered it. So we will cover the terms next time. Plus we've had some proposals sent in, which is good for next time. So send me an email if you would like to come next time, and because you've done the preparation.
Yeah, and if you're not able to attend next time, you can always listen back to these or watch these webinars on the YouTube channel.
That's true. Thank you. So let's have a look. Please continue for those who can stay and the comments coming in. Please feel free to go ahead. People want us to stay. I'll hand over to you, Carol-Anne, for our last COVID example, and then we will have done 8 today. 7 today.
So, okay, here we have it. We have now arrived at our last COVID-19 example that we had prepared for today. It is reported here that upon arrival, the vials with the vaccine were removed from the transport box and left out all day before being moved to the clinic fridge overnight, instead of the designated COVID-19 vaccine fridge. Staff not aware of this error and then administered the vaccine to 30 elderly patients. So why is this at all reported? Well, it's clear there was somehow a storage error, and then this vaccine where this storage error happened, then was administered to 30 patients. So is this now a medication error or a product quality issue or both? And how can we best capture it? Always takes a while until I can move forward. So what are your suggestions here? Product storage error, temperature too high.
And poor quality vaccine.
Product storage too high, poor quality vaccine administered, out of specification product use.
Out of specification, that's an interesting one, Caroline.
Yeah.
We talk about that one if we've got time. Product storage error, temperature too high.
Product stored in wrong location, medication dispensing error, product storage error. So again, split opinions, but many of you voted for product storage error, temperature too high, and then also administration error. Now let's browse Meta again in order to find suitable terms for our verbatim. Here we are. Let's switch back to the release view. And here we are. So first of all, we have a storage error. That is clear. So we would look into injury, poisoning, procedural complication under medication errors, and then you will see HLTs that reflect the stages of the product use issues or errors where they occurred. And we have an HLT also for the product storage errors and issues in the product use system. So when the product is used in the healthcare system. And here we have 3 PTs, and one of them refers to the product storage error and the most appropriate here. So we have no vaccine specific terms that would be available. Some are quite vague, but here we have one that refers to temperature, one too low, other too high. So this would be the correct term here to assign for the reported incident, the storage error. So the vaccine was stored at a temperature that was too high.
Caroline, can we share with the group the discussion we had yesterday when we were working out what is a medication error? And it's in the companion document, isn't it? We've referred to it that when a drug becomes in the control of the health use, the product.
So you will find this definition in the concept description here, the medication error. Any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. So it's really when it is under control of in the medication use process in the healthcare environment.
Yes, because they're in the clinic now. They've taken it out of the box for transport.
It was taken out of the box of the clinic, and one of the hospital staff members didn't follow the instructions and left it there for one full day, and then even didn't put it into the right fridge, but into the regular fridge, not into the fridge with 70 degrees Celsius, minus 70 degrees Celsius or more.
It's not a fault of the transport. It's not a defect in that way of the supply again, is it? It's due to the clinic. It's in a clinic setting, so it's a medication.
So you will see that what is interesting to see that you will find similar terms in the product issues SOC. Here, the product distribution and storage issues. Here you will find product distribution, temperature, excursion issue. So this would be something that would apply to our scenario, so that the temperature was either exceeded or it was too low. That is described in the manual. So how the product should be stored. How to differentiate those? So the reason for this distinction is that distribution and storage issues are not considered medication errors if they are caused by manufacturers, distributors, or wholesalers. Remember the definition that we just heard. So medication errors, you would only consider this a medication error when this vaccine is under control of the health HCP, patient or consumer. So this is why you will find similar PTs here. But what we know here is that the boxes were already at the clinic and one of the hospital staff members did the error. So it was actually an error. It was a medication error, a storage error. So, but with this one term that we had under the injury SOC, here we only capture one part of our verbatim. And we would need to look for another term as well. That is, I have to move back. Somehow I made a mistake here. We have to look for another term that would cover the additional information that we received. That is that the vaccine was administered to 30 elderly patients afterwards, because the staff members, the nurses, or the doctors were not aware of the storage error. So we would need again to look into the injury SOC. Here we have the product storage error, but now we would look into the product administration errors and issues in order to check. Or we could also do a top-down search here, or we could look for quality, for example, and admin, and check whether we find something directly here. And here we are. Poor quality drug administered, poor quality vaccine administered.
Poor quality.
And you see when I go to the browser, here it is. Poor quality product administered. We have the specific LRT here, poor quality vaccine administered, because of course we know that if the drug is not stored under the required conditions, the quality is put at risk, so we can suspect the poor quality, and with this we would capture the fact that it was administered, the vaccine was administered, very important information that needs to be captured, and that it had a poor quality. This was the error. Shouldn't have been administered.
So we used to have that in our coding conventions. When I worked in the industry, having that when the drug wasn't stored correctly and then was administered, we did make that, I'd say, assumption, I suppose, or poor quality vaccine, poor quality drug administered. So that's another example, isn't it, where you could have it in your conventions internally.
Yeah, yeah.
Because nobody has said, is that an assumption? But I always have to say in my head, do I feel comfortable? Yes, that's that. Because as you say, Caroline, it's putting the safety, the quality of the drug in jeopardy.
Yes. And regarding the question related to the specification, so this was not reported. We can assume that the product now has a poor quality, but it was not specified, so it was not tested. So this is not what has been reported.
So I had a look at, it's interesting that somebody said that, because when I was doing the prep yesterday, I noticed the out of specifications and I looked up to see what's the definition, if you like, for out of specification. Yeah. And that's to do with testing, isn't it? Because I wasn't exactly sure. I thought someone might raise it. It's to do with the testing during the manufacturing process. So you know that there's something wrong with it when it leaves the factory, if you like, the quality testing process. And so that's why now there's an error. That's why the quality is deteriorated, because there has been a medication error.
Yeah, you could, of course, test it afterwards, test it against the specifications, but what we can suspect already that it has a poor quality, that it would not meet the specification requirements.
So you'd only use that out of specification if the testing had been done either, as you say, ad hoc or part of the standard process. So we've got a question, if you can cope with a couple more minutes, Caroline. The last question, somebody's asking us about the use of expired product instead of poor quality. As I say, we used to use poor quality in the company I worked at, but we're being told that in...
Yeah, that's something different. Expired product administered would mean that it is beyond the document expiry date that is provided on the vial in this instance. So then you would use expired vaccine administered or expired product administered.
And that's what, apparently that's in the PTC. So thank you for that. In the PTC, it tells you about using expired. So if you have a similar example, you wouldn't use expired in this one, but if you have a similar example where the drug's been given and it's beyond the date, past its sell-by date, its use-by date, then that would be, you could use expired product, but we don't have a specific term for a drug that's been stored wrongly and then given.
Yes.
Vaccine. So thank you for your input on that one. That's great to hear.
So these are the learning points again. So we have to capture all that has been reported, in this instance, both the storage error and the administration error. And we have to clearly distinguish the product use issue terms that were caused by manufacturers and wholesalers or distributors. So roles that are not involved in the actual product use process, from the medication errors, from those that are caused by HCPs, patients and consumers. Only then we would talk about medication errors. So those who are caused, that are caused by manufacturers, wholesalers, distributors, they are not to be considered medication errors or use errors, based on the companion document again. And you can also find a related concept description, product storage error, in the concept descriptions in the Medra browser. Any further questions?
No, that's all the questions we've got. Somebody's asking us, can we share the slides? And I've just explained that we tend to share the recording and not the slides themselves, because you really need the discussion that goes with it and not just the slides. So you can watch it back, but that's why we choose not to share the slides. Otherwise, no, we've got no more comments on that one at the moment.
Okay. Would you like to show the references, Jane, or do we skip that?
Do we have the references at the end? At the end, you mean?
Yeah.
I think we have our survey, and that's all we have. I don't have the references today. Do you mean the website?
Yeah. Go to the website.
You can
contact and then you find the.
We can go to the website and just show people. Do feel free to contact us at the help desk. There's the live chat that some of you may have used before. Are you going to? Should I do it, Caroline, or do you want to do it?
I do it. Yeah, I do it. If you go to contact here, you see the YouTube channel. You need
to share again, Caroline. I'm sorry. You'll need to share again. I'm sorry. That was my fault.
I think you have to give me control. I cannot take it directly.
Yes, there we are. Sorry.
So if you go to the Medra website and you click on contact here above, then you see the help desk email address. You see some social media channels in different languages, but you also see the link to the YouTube channel here. So if you click on it, you are directly brought to our YouTube channel, where you can find the recorded sessions also of this webinar. Hopefully the audio will be fine. but we will have the same session today in the afternoon for the American time zone, so for North America and Latin America. So one of these sessions will be recorded, only one will be posted.
Mm-hmm. So there are only a couple of comments coming in. Where do we find the recordings? They're on the YouTube channel. And again, we've got a couple of comments around the issue of the poor quality drug versus expired. So that's something that we will take away and we will look into. As I say, our reading of it, we feel that the poor quality is better, but we will double check that. We will go back and reference the things that you've mentioned, as well as looking into it again, just to double check. Okay, yeah. Before we do the session later. So thank you for your comments. Thank you for your interaction. As I say, you will have, as well as the survey you've done now, you will have another follow-up survey given to you. I hope that you will join us again for our future sessions. We enjoy doing these sessions, don't we, Caroline?
Yeah.
It's good fun. So yes, do get in touch with us. Any comments, any suggestions, and we hope to see you again at a future session. So enjoy the rest of your day. Thank you for your attention. Thank you, Caroline, for our collaboration today, and we will reconvene another month. Thank you, everyone. Thank you very much. Enjoy the rest of your day. Stay safe. Bye-bye. Bye-bye.
Bye-bye.